Well, guys, should we get started? I'm glad you guys came out today. This is my first workshop in my office. I'm Dr. Todd Lloyd. I built this office about a year and a half ago, so I've been open about that time. But this is our first workshop. I designed this part of the office to be open like this for day-to-day care. We do some chiropractic, we do some rehab stuff. In the future, I'm going to put down some mats so it's easier to get on the floor and do things. That office right there, that cubicle, is more for new patient intake and examinations. So I've been here for about a year and a half, just slowly ramping up. So I thought I would kick it off by doing a shoulder pain workshop, rotator cuff. So I assume that all of us have rotator cuff issues. I do too. Mine came about when I was like 20 years old. I was playing with a dog in the backyard. I was throwing, I think it was like one of those rope toys. Dog was behind me, grabbed onto it, and sort of like just yanked me back. Ever since then, I've got a little bit of a click in my shoulder. It's probably rotator cuff, probably a little bit of an impingement in there. Have you guys been diagnosed with rotator cuff problems? Tom, I talked to you on the phone. You're bone on bone.
That's right. Well, it's been a long time. I started mine in high school. That's how long ago that was.
Yeah.
But then I reverted to playing soccer, which I played professionally, but I was a goalkeeper, which wasn't the best thing.
Yeah.
So yeah, but then I had a bad fall about 11 years ago, almost to the date, when I whacked my shoulder into a wall, a brick wall,
Mm-hmm.
and the orthopedic surgeon on call at the time said what little bit of a rotator cuff connection I had was long gone.
So are you able to reach up over?
Not like that.
How far up can you go?
That's it.
Maybe else?
Then I can do that.
Yeah.
But yeah, that's
So you're really,
that's it. Yeah.
yeah, that's really disconnected. I'm assuming not everybody's like that.
I hope not.
I talked to you this morning. You were shoveling gravel out of the truck the other day.
Yeah, like I've always done.
Yeah.
But
Tell me your story again.
This just started a couple months ago.
Mm-hmm.
At age 73, I've always done a lot of stuff and I can't stop. So,
Well, you look like you're 53.
oh, well, thanks. But, you know, it is what it is. And I can't stop doing what I'm doing. So,
Yeah.
because I just simply will do what would I do and who's going to do the work I'm doing, you know.
Right.
And I also have a big dog that pulls, so I try to hold her with the other arm. So I'm here to see if I can get some tips.
Yeah, you were telling me earlier that you can't slow down in life. Because once you
No,
slow
I
down in
can't.
life,
And I guess it'll take something really big to really bring me down.
yeah.
But, no, you know what, I do all the maintenance on my property, I like doing it, it's what makes me happy.
Mm-hmm.
And I look at what I've done and it makes me feel good, you just can't take that away. So, I mean, at least I refuse to let it, you know. But yeah, I'm having pain and I thought I was sleeping on it, weird.
Yeah.
And it's like, no, because it's still there and I'm sleeping on the other side and it still hurts. And so I guess, you know, I just have overdone it.
Yeah.
Maybe worn it out.
Can anybody else relate to that? Shoulder degeneration, rotator cuff tendinitis, impingement syndromes, really important, or really common, especially after the age of 40. But then it tends to deteriorate more and more. We get deconditioned. Yes?
Yeah, so question, so mine I know is bone on bone, I've had an x-ray, and, but I don't think it's rotator cuff. How would I know the difference?
Well, it's tricky to know the difference.
Okay.
And if you have some sort of an impingement in your shoulder or degeneration, You probably have some rotator cuff tendonitis too.
Okay.
Are you able to raise your shoulders overhead, arms overhead?
Then when I hit the key.
About right there. Yeah, then you have to kind of lift it up like
Now this I can do.
you can go forward.
With this.
Mm-hmm.
It's this that hurts.
And it pinches.
Here.
Yep.
So I don't know.
So you had an x-ray done too, sort of like bone on bone. There was an MRI.
It wasn't an MRI, it was x-rays
Yeah.
on those shoulders with bone on bone because I'm not trying to solve it.
Okay. Anybody else wants to share their story?
I'll go really quick. I
Okay.
just developed something. I don't know what it is in my left shoulder. I carry my purse there. I'm carrying a smaller one now.
Mm-hmm.
But it's painful at times. I think it's right in here, but I haven't had anything checked out with Kaiser.
Okay. And you're able to elevate up?
Yeah,
Okay.
I've got, but sometimes it's painful when I do that. So
Yeah.
sometimes I can locate right where it is and it gets better and then it gets worse.
And sometimes there's a painful arc. And then once you get past that arc, it's fine. Is that your case?
I think I could do it. Yeah, I think that's.
It's like painful through here. But then once you're past that, it's
Yeah.
okay. All right. Okay, well, I've got a worksheet to work along with. I've kind of forgot what's on there. Maybe we should start filling that out. But before we do that, let's do a little bit of a warm up. I'm going to have everybody stand up. So we're not going to stress the rotator cuff with this warm up, but we're going to shrug our shoulders up, bring it back, shoulder blades back, bring it forward again. We're going to circle around our shoulder blades. To sort of get everything moving better. Looks like we're all kind of going back. Let's go forward again too. Anybody have pain with that? Yeah, a little clicking. Yeah, it does feel good. If you have, in my experience, you have someone sitting right here, I take their shoulder blade and do the same thing passively. It feels like a massage. So this is a warm-up that feels really good. Are you guys able to sort of like circle your arms down low? Well, that's not so bad. Tom, you got it.
Yeah.
Do some circles, and then go backwards too. All right, that's pretty good warm-up. This is pretty similar to what we do at the CrossFit gym, although we kind of bring it more out like this and are yelling at us more. So that's like one of our warm-ups. Can anybody go straight out? Yeah, pretty good.
I can't do the right.
Okay. All right, that's our warm-up part. We're going to learn a little bit more how to get back to normal without medications, injections, or surgeries, because we don't do those here. First, that's me. This is the doctor presenting today. I don't know what else to say about that. I don't want to talk about myself. But I've been in practice for like 22 years, this office for a year and a half. Prior to this, I was in Sonoma. I still am in Sonoma part-time, San Francisco, but now I'm making my transition to this full-time. But I'm not the best doctor for you. The best doctor is these 6 doctors. Healthy eating, social time, outdoor walks, exercise, rest, and sunlight. So what we're going to do is we're going to talk a little bit more about the exercise part of the shoulder rotator cuff. I think all of this is pretty self-evident. We all know about this. Good rest. Although if you're resting on the rotator cuff, that's not very comfortable. So what is the rotator cuff? I think this is on the paper. The rotator cuff is a group of 4 muscles. I've got 3 right here, but it's 4 muscles that stabilize the shoulder. I should have given you a worksheet, no? Okay. All right, I'll give you a little tour. You don't need to know the words of these muscles. And that's not the answer to number 3 either. So we don't need to know the names of the muscles, but we have the supraspinatus, which is the most common one involved.
Is that the big tendon?
Pardon me?
There's that big tendon that goes,
The tendon?
yeah.
Yeah, so what happens with these muscles? It starts out as a muscle attached to the shoulder blade. They come across, and then underneath this bone right here, it turns into a tendon as it attaches to the humerus, the shoulder, the arm bone. So the supraspinatus, you probably heard that before if you had an MRI or an X-ray report that shows degeneration of the rotator cuff. Supraspinatus is called that because supra, it's above the spine of the scapula. And so if you see an MRI report of your torn up rotator cuff, that's probably going to be mostly the supraspinatus. That's the one that does this. And so supra, this is the spine of the scapula above the spine. We also have the infraspinatus, which is below the spine of the scapula. That's this one. This one will elevate your shoulder like that, abduct it. That one will rotate it out like that. The other one that rotates out is the teres minor. That one's less involved with rotator cuff problems. It's mostly the supraspinatus. I do a lot of personal injury cases in this office too, where I'll send for an MRI because the shoulder becomes damaged from an injury, car accident. And I see a lot of the MRI reports come back supraspinatus, like an acute injury. On the MRI, you can see like the nice white tendon, but it turns dark because it becomes filled with fluid. So the fourth muscle in the rotator cuff is the subscapularis, and this is the front view of the guy. That's the muscle right there. It's behind the rib cage, and as you do this, that's the one that's close to the ribs. Turns into a tendon, attaches to the arm bone. That one gets involved sometimes with an injury too, but most of the time when you have sort of like an old injury, it's going to be the supraspinatus. If you're bone on bone and you can't lift anymore, it's probably because the supraspinatus has been torn away. And it's a painful one to rehab too. So if you grab like a weight and you bring it up with your thumb down, that isolates the supraspinatus muscle, and that can be really painful when you're trying to rehab that. And the other problem with this too is that this bone at the top of the shoulder is called the acromion. That will degenerate too as you age, and it forms a hook that can dig into the muscle and tendon. So if you start doing aggressive exercises, it's going to start to become painful, and that's no fun. So we'll work out some strategies for that. This is an injury to different parts of the body. So we have muscle on top, ligament sprain, and then a fractured bone. Fractured bone is a much shorter process for healing. Does anybody know why? Why does bone heal faster than ligaments?
Because there's so much blood in them.
Good blood supply.
Yeah.
Bone marrow. So if you fracture a bone, it's pretty quick. I forget how quick it is. It's like 6 weeks or something. I don't know. But the bone marrow is a really good blood supply, and it heals fast. It lays down more calcium, and your bone is fractured. Also, good blood supply is the muscle. Muscle, if you have a muscle tear, it's super painful, but it goes through the whole process. It sort of looks like it's the same timeline as a ligament here, but it's much faster than a ligament. But a ligament here, ligaments have a very bad blood supply, so it takes much longer. And actually a ligament can take up to a year to heal properly. So this is like a best case scenario. You're an athlete, you're young, you have an injury. This is the timeline. 1 to 2 days, you have this active swelling where you're bleeding. 2 days to 15 days, you have this inflammation stage where things are swollen. There's lots of, the swelling and the pain is protective of the injury. After that, the swelling starts to go down, but then you have this proliferation stage. And this is the part where the two ends of the torn tissue start to come back together. And the whatever wound starts to contract. And then that after about a month of that, you're in the remodeling stage. That starts about day 15. But the remodeling stage goes up to a year out for a tendon. Now the remodeling stage is when you have all these different cells that have come in, they're starting to lay down more collagen fibers. So I want to show you this here. This is a band for exercise, but it's kind of old and worn out. But if you took a microscope and looked at your ligament, you could see the fibers in there, how they're designed to go in that direction. They're not designed to go this way, and they're not designed to be compressed. But that action where they go like this, you can see the little fibers in there doing their job. It's kind of the same way for the ligaments and tendons in your body. Under a microscope, you can see this one is all torn up. Well, if this is living tissue and I started to stimulate that more, those fibers will start to line up and the cells in there will grow more collagen fibers in that direction. That's this collagen right here. And what you're left with proper rehab is functional training is possible to heal tissues stronger than their pre-injury ability. But that's in the best case scenario. What happens a lot with rotator cuff though is that you keep on using it and abusing it. Certain parts will grind on the tissue. And so you might be like stuck in this proliferation phase and you're getting better and better, then all of a sudden something happens where you grind it the wrong way and you have to start over again. That's repetitive injury. And that's why so often with rotator cuffs we have incomplete healing and we have scar tissue that gets deposited in there. And the MRI report shows that the once small tendon has become thickened. So that's the mechanism of injury there. So that means we need to be a little more gentle on our rotator cuffs than maybe if it was a rehab for a different body part. And going too aggressive with exercises might be going backwards for us. So we want to set up a good foundation for the way the shoulder works better. And these are 4 areas that work together to make the shoulder work its best. We have the neck, the collarbone, shoulder blade, and the rib cage. All of these need to be in good alignment. We need to have good neck mobility, good collarbone function, good shoulder blade mobility, which is usually not a problem. But the shoulder blade needs to be in a good posture too. And the rib cage needs to function well. Sometimes the upper back becomes stiff and stuck. And we become stuck in a kind of a hunched posture. So we want to make sure that all of these 4 areas are working better to help the shoulder joint have its full mobility and develop that enough space in there to avoid re-injury. So that's the answer to number 3, the 4 areas that work together during shoulder movement. Oh, answer number 4, who is Dr. Lloyd? That's just me. But here's an important one, number 5. Is your pain reproducible? I think for most of us it is. You start to lift your arm up and it becomes painful. And if you can identify what parts of your life you feel the shoulder pain more, then you can better take care of it. So are you reaching overhead and it's painful? Carrying objects, lifting, reaching behind your back? Can you go behind your back to scratch your itch? What about getting dressed and putting a coat on? Or is it reproduced in sleep? Are you laying on it? So these are all clues that we can use, because what we find is that if your pain is reproducible, your pain is also reducible. So you can avoid certain activities, but you can also strengthen yourself when performing those activities. So if your pain is not reproducible, like you have pain all the time, that's more of a red flag. Maybe you have a tumor growing in there or something that we can't help. Maybe it needs more advanced imaging or something. But if your pain is reproducible, then it's reducible. And that's the answer to number 5. I'm glad we got to that. Let me take a survey of the room. In the past 30 days, the worst pain you've had on a scale of 1 to 10 was what? 0 being no pain, 10 being the worst pain you could ever imagine. Anybody want to share that experience? Is it a 5? Tolerable but really painful? Is it worse, like an 8? Usually these chronic problems, you know, you really have to abuse it to get above a 6. Okay, I have pain when doing that. You can keep track of your own thing, lifting, carrying objects. Oh, number 8, the number one mistake shoulder pain sufferers make. Let's see if that's the answer is on the next slide. What do you think it is? Is it a mistake to handle it, to alter it, or to ignore it?
Handle it.
Is that the biggest mistake?
I think. Well, no, well, I was thinking,
Because it'll get worse.
Handle it, it's showing a guy exercising, but handling it is also going to the doctor and having it checked
okay.
out.
Yeah, I misunderstood.
But it's human nature to really ignore the pain. But that's also a way to sort of decondition parts of your body. Muscles get weak. You lose that range of motion. So anybody above 40 years old out here in the general population, if you did an ultrasound study or an MRI of their shoulder, they probably have some kind of rotator cuff problem too. And maybe they have occasional pain. They might not have pain, but most people ignore it. That's how I would do it too. If it's not hurting me, or if it's just hurting me in certain situations, I would probably ignore it too. I have chiropractor friends, though I get adjusted a lot, so if I have small problems, I would bring that to them all the time, but it's in my nature to ignore pain. If it's persistent pain, another thing to do is alter it, which of course shows medications. But handling it is maybe going to a chiropractor or a physical therapist or a physiatrist or your general practitioner, asking them for, you know, something that is more than just a medication to help with the pain. And maybe,
What are those categories that would you fit in if you just learn to live with it and don't do certain things?
you
When
could.
I had my first injury way back when, in the dark days, medically, the doctor said that the only thing they could do was with I think it was tendons he was talking about. He said at best I might get 70% of my range of motion back, but he said, yeah, other alternative would just be to learn to live with it, which is what I did.
So you could do a combination of ignoring it and learning to live with it,
Yeah.
but you need to be proactive too. So I'm not saying pick up weights and doing overhead presses like that graphic shows, but what you should do is to work on range of motion. Now, if your tendons are all shot, you still have these muscles above the rotator cuff, deltoid. So you could even if it's painful, you could do a wall walk.
Yeah, I can do that.
Yeah, so you should be doing this probably every day.
Okay.
Get that range of motion back in there as far as you can go. Now, at the end of the range of motion, you're stretching out muscles down here, but you're also stretching out the joint capsule in the shoulder, and you're keeping that range of motion back in there. Anytime you move any joint in your body through its full range of motion, you're bathing it with nutrients. So maybe your tendons are shot and you can't do that on its own, but you should preserve the cartilage cap on your shoulder by working its range of motion every day. So if it's pain that's not life-threatening, you can ignore it, but I'm saying be proactive with it, work on the range of motion. And if you've still got some of that tendon in there, and maybe it's a little bit shot, it's good to get the muscles engaged too. I'll show you another idea. Maybe it's already on here. Oh, here, look at this. Here's the fear avoidance model. This is actually the consequence of ignoring it. So this right here is when you first get injured, and that injury causes pain. This could be like when you're 20 years old and that's the first injury you ever had to a shoulder, or it could be when you're 70 years old and you injured it again. But the response to that is pain. And pain is threatening information for your brain. And that's when you have the withdrawal reflex and you learned from the school of hard knocks not to do that activity again. That pain makes your body think it's in a catastrophe. So we tend to catastrophize the pain. It's okay to be on guard when you have pain, but when you have too much of a response to it, that's catastrophization, and that leads to this pain fear avoidance model. The proactive way of handling the pain is to know that the pain is not currently damaging you, and to be more proactive, to return to activity, get the muscles engaged more. Does that make sense? But this is withdrawing from the painful stimulus. And what this does is it makes you hypervigilant to avoid more pain. You start to disuse it. It becomes atrophied. It's deconditioned. And that leads to re-injury and more pain. And pretty soon, years go by, you're not using your shoulder anymore. It becomes stiff. It becomes painful. We got to break that cycle of pain and avoidance and start to become a little bit more proactive. So, just a quick exercise, knowing what we know about the fibers, maybe some scar tissue in there. If we grab a small weight, or even just our arm, and we bring it up to a pain-free range of motion, and we hold it there, what's going on there is the muscle is contracting to stabilize what the arm is doing. If you have an intact tendon, that tendon is under a load. And what we're doing here is an isometric contraction. Nothing is moving. Isometric means the meters in there aren't changing. Nothing moves. And so as we hold that for about 30 to 45 seconds, there's that stimulus inside the tendon, those little cells in there, to grow those collagen fibers. So this is a process that takes time, of course. Anything you do for this rotator cuff is going to take a lot of time. So you hold it right there. And maybe if you're good at that, you can hold a weight, like a can of soup or something that you can tolerate. And then you let it go and let it relax too. This is taking you away from this deconditioning pain avoidance cycle and moving you more towards being proactive. Does that make sense to you guys? The other part of that, let me see if, yeah, okay, here. That's optimal. Optimal is when you don't provoke it too much, but you're also doing stuff to heal it. If you're too hard on yourself, you're being counterproductive. This right here represents like a baseline of function. If you're too hard on yourself and it causes inflammation and swelling, you're re-injuring it. It resets the baseline to lower and lower levels. Look at that poor guy. Too easy though, you're not really changing it, and maybe you're still doing fear avoidance. So if you can do optimal and you're proactive about it, you're doing some weights, you're stretching it out, you're working on the range of motion, then you're resetting the baseline to improve more and more until you finally start to get some of that shoulder range of motion back.
What's the timeline? Months, weeks, years?
Could be years. Takes a long time it's not very rewarding. Tendons and ligaments take a long time to remodel. Muscle, you can see results faster. But yeah, especially the older the injury. So, I mean, you could choose to ignore it and live the rest of your life with just that recurring pain, but might as well work on it bit by bit, make it a new habit. What's next on our list?
When you mentioned that isometric exercise, I noticed you turned your hand this way
Oh yeah.
rather than this way or that way.
Yeah, the reason why I do that is because if you turn your thumb down,
Yeah.
it rotates your humerus, and that lines up the supraspinatus muscle better. But Actually, the studies show that you can just pick up a weight and do this too, and that's going to stimulate that muscle just as much as if you do this old-fashioned supraspinatus. This is called the empty can exercise. Like you take a beer can and empty it out, and you go like this. You don't go above, like, what is that, 75 degrees? You don't go above 90, but that's just getting that supraspinatus going better. Up about this angle right here, you're starting to hit part of the humerus against that acromion bone. So you're kind of getting more bone on bone. You have to rotate out in order to clear that barrier. So in this first part of the angle, that is only the ball and socket joint. And once you go past that, then you're having more shoulder blade movement, scapular movement to reach up high. More on that in a second. Because we have three common causes of shoulder pain. This is number 10. Oh, number 9, the 3 things you can do about your shoulder pain right now. Did you guys get that? You could ignore it. You could mask it. You could alter it. Mask it with drugs. Or you can handle it. Okay, the top 3 common causes of shoulder pain. Problem in the neck. Why would the neck cause shoulder problems? You guys have any ideas?
If you don't stand up straight, shoulders back, take a deep breath.
Yeah, there's a lot of muscles attached between the neck and the shoulders. We have levator scapula muscle right here. These rhomboids kind of go to the lower part of the neck. The upper trapezius. And so if you have poor neck posture, that could put more strain on the shoulder.
Sleeping on too many pillows?
Yeah.
Cause you to, I was just wondering if maybe I was sleeping on too many pillows.
Well, that could make your neck worse and worse. Which could make that problem worse, which could lead to problems with the shoulder too. And it's a little bit more indirect, the neck problem. But I put neck first because as a chiropractor, I work on people's necks, and I see that if someone's got a torn up shoulder or even like a tennis elbow, they usually have a neck problem on the same side. And one of the problems too, it's not always the case, the nerves that go down the arm, to the shoulder, to the hand, they start in the neck. C4 through T1, these little nerve spaces where the nerves come out of the spinal cord, go to the muscles in the hand and the shoulder, of course. So nerve impingement in the neck can cause problems in the shoulder too. Now the other common cause of shoulder pain is an impingement in the shoulder itself. And that's when you re-injure the tendons in the rotator cuff by this constant use. But there's less space up there because of maybe a hunch posture. So that's kind of like that re-injury to the tendon in the shoulder. Impingement syndrome. And this is also, it's never just a rotator cuff problem in isolation. You've got impingement syndrome that can lead to also a bursitis, which is the irritation of the bursal sac, which provides more of a slippery barrier between the shoulder bones. It could be that you have a tear in the labrum of the shoulder, which is peeling away and causing problems too. So it's never just the rotator cuff in isolation. So that leads to posture, and the poor posture will also cause more of that impingement syndrome too. If you have a poor posture, what happens is your shoulder blades roll forward, and it creates less space for the rotator cuff muscles. I need a volunteer, and I think you're just the one to do it. Can I use you as an example? Have a seat right here. Which side is your
Left.
The left side? Okay, I'm just gonna see how this moves. You don't mind, do you?
No.
Okay. That's actually not too bad. Does that hurt though?
Not right now.
Okay.
Sometimes it does when it's out to the side.
Must be the table is fixed already.
It's a miracle.
Yeah. Okay, you have really good shoulder range of motion. I think it's better than mine. Let's try this though. I'm gonna have you slump a little bit. Yeah, like that. All right, this is me on my computer all day.
Driving.
If I had a computer, driving. So if I do this again, that's about where we get it. Do you guys see a difference there? That's even worse on this side, so maybe we do have a problem in there. This is how a lot of my patients come into. I think maybe exactly. But they're not self-aware.
Yeah.
You're very self-aware about it. So if you improve your posture, that opens up this space right here where you have full range of motion again. And look how good that is. But if you slump again. All right, see, that's about all we get. And does that hurt when I do that?
A little sore, not
Yeah, you get a little bit of
discomfort.
impingement. Let me just see here. If I press right there, does that hurt?
No, not now, but that is one of the spots.
Yeah, okay. I won't abuse it then.
Thank you.
Thanks for letting me use you. That's one of my tricks I do with my patients. Get a new patient in here, they're sitting there like this. Oh, look at this, that's horrible. And then I just press on their back, get their posture upright again, and they have good range of motion again. So, posture, that's definitely a part of the shoulder pain or impingement syndrome. Does that make sense to you guys?
I have a question.
Sure.
So, wouldn't osteoporosis affect that too?
Osteoporosis is just thinning of the bone.
Yeah.
There's osteoarthritis.
Yeah.
That's arthritis. That's the wear and tear arthritis. That is part of the whole deconditioning syndrome. That thing. Osteoarthritis happens when it might be a little bit inflamed, but you stop using it. And when you stop using the full range of motion of your joints, it could be your neck, it could be your shoulder or your knee, and maybe there's an injury that sparked it, then you start to lose the collagen thickness in the joint, and that becomes stiffer and stiffer as time goes on. So if you had severe arthritis in your shoulder and I did that trick, then maybe you'd have this, but then your posture would be upright. You might have a little bit more range of motion, but you'd still lose some of that range of motion. And that would be an osteoarthritis thing. Osteoarthritis in your neck or your low back, that's when you wake up on your 40th birthday and you're stiff. That's a little bit of osteoarthritis. And if you took an x-ray of someone's low back where they wake up stiff in the morning, they might have bone spurs, narrowing of the discs between the bones, and that's osteoarthritis. That causes problems because you lose your range of motion, and with that, you sort of lose strength in the muscles that surround, like your low back, for example, or in your neck. You're going to lose that range of motion too. It becomes stiff in extension. And maybe I'm speaking for myself, but the muscles just don't have that full range of motion to play with anymore. Make sense? Yeah.
So, coming back to the pillow thing, I find that sometimes having more pillows for my head that allows this shoulder to have space. Because I like to sleep on my side.
Yeah.
But, to her point about then what's it doing to my neck? So I'm just not sure how to have pillows so that it protects my shoulder but doesn't twist my neck.
So you're a side sleeper?
Yeah.
So you're going to want to have more pillow that will cover this space. Now, when you're on your side, you're not on the point of your shoulder, right? You're not like this. You have to be on your shoulder blade on your side. And you have to have enough pillow that will cover that space. So it's not like you have to cover the whole space between your shoulder and your neck, because that would be kind of hard to do. That would be really, really uncomfortable on your shoulder. So whenever we sleep on our side, we're actually on our shoulder blade, and that's more appropriate.
And does that hurt my shoulder to be like that?
In most people, it wouldn't.
I mean, I seem to sleep fine that way, but
Yeah.
I do have the pillows sort of in there.
We have a lot of cushiony muscle that cushion you that way. But if you tried to sleep right in the point of your shoulder, that would be really painful.
Right.
That would really irritate it. So the point is, though, you don't need a pillow that's this big. You need a pillow that kind of covers the space between.
Just a smaller.
Mm-hmm.
space.
Actually, I have those pillows over there are custom measured. And if you guys want, I can measure you too. And the algorithms that they use to determine what pillow you should get is determined on whether you're a back sleeper or a side sleeper. And then we measure across the shoulders, measure between the shoulder and this part of the skull and around the neck. And they give you what size you should have. So if you want, we can do that too. And I think we're about done, so.
Cool.
Can you say what, on question 3, what all those were? I have neck and collarbone, but,
Shoulder blade and rib cage.
okay, thank you.
Check out the A student up front row.
Old English major, I'm used to taking notes.
All right, let's wrap it up. I'm going to tell you about what I do in my office. This is what successful treatment looks like here. Could be someone else's office too, but we find that hands-on care helps with good bone and joint mobility. So as you sit there and maybe you've got some pain between your shoulder blades that is causing you to slump, good old-fashioned chiropractic care helps with that, or getting the neck moving better. So this is all pretty powerful stuff. Improving your posture, so as you get off the table, it feels like there's less pressure in there, then you can start moving your shoulder more. Do you guys have experience with chiropractic care? Yeah. So a combination of hands-on chiropractic care, and this could be like, this presentation was actually developed by a physical therapist. So this is developed by a physical therapist who does manual therapy too. So they might do some stretches and mobility stuff for the spine, the neck, and the shoulder. But that's part of the hands-on care. That's hands-on care that anybody who comes into my office gets, whether they have a rotator cuff problem or not. The other part that is probably the most important, it's definitely the most important, is doing your home exercises. It might be doing the empty can isometric. It could be doing the wall walk. It could be just doing our warm-up that we did before. And that all depends on your ability too. So if you've lost all the tendon, you can barely lift your shoulder up, you've got to modify it a little bit more. And so in a class or a workshop like this, it's really hard to determine, it's hard to do a one-size-fits-all. So for example, one thing I do for some of the people I do CrossFit with is I'll have them take a kettlebell, go upside down with it, and do this halo exercise to help strengthen the shoulder as well as stabilize the neck. So I can't expect everybody to do that. So it's never a one-size-fits-all. So that would not apply to most of us in here. But doing the wall walk to get the range of motion back in there, grabbing a smaller weight, working on the range of motion that way, going in front, and just working on the range of motion of the shoulder is a good home exercise. Home exercise also includes mobility, so you might do a doorway stretch like that. And then real quick, I'll show you this one too. You might lie on your side and sort of work the rotation that way, just to kind of get the muscles engaged. And all that stuff is important for... Did you guys know I'm recording this? All right. So home exercise. And the other thing I have in this office, if you're interested, is shockwave therapy. So shockwave therapy is sort of a newer technique, a new modality that was brought over from Germany or something 20 years ago. It is similar to lithotripsy if you have kidney stones, but a little bit different of an applicator. But this shockwave therapy is a way to send a sound wave deep into the tendon to help agitate some of the fibers in there that have been stuck in the wrong process of the healing process. It actually will help dissolve away some of the scar tissue that has infiltrated there over the years to allow better mobility and better extensibility. It sort of hurts when you put it on. It kind of feels sour, like it's painful. But it's penetrating deep into that tendon to help with that remodeling process. But once you get done with that, it feels pretty good. I have a patient in San Francisco who had foot surgery or ankle surgery. He came in, he's about 70 years old. He had a really big ankle from all the scar tissue that was in there. So we started doing shockwave on him twice a week. And we saw it just shrink down more and more as time went on. He came in, he had to wear like house slippers instead of shoes because his ankle was so big. But we eventually got him to the point where he could wear lace-up shoes again. So it helps to dissolve scar tissue, and it makes the other therapies more effective. So just so you guys know about that. And there's the pricing right there too. My first exam fee is the same for chiropractic and for shockwave therapy. And that usually includes the treatment too. But then the shockwave is a little more expensive. It's $145 a treatment. Treatment lasts about 20 minutes. But you're going to need at least 6 visits with that, and sometimes 12. So I put together some packages where you can save some money. And if you're interested in this, I have the price list up front too.
Does Medicare cover any of that?
Medicare covers chiropractic visits, but not the exam, and it does not cover shockwave. No insurance covers shockwave yet. Not even Kaiser. All right. You guys have any questions about any of this? Do you want to get measured for pillows? Do you want to feel what shockwave feels like? Do you want? Okay.
Yeah.
We can do that. It's got to be skin on skin. We can probably do like an elbow too, if you can access the shoulder so easy. Yeah, why not? Let's go in there. Let's take a look.